All right, everyone, welcome to Dental Nachos CE on TV. This is Paul, Dr. Nacho Goodman, doing one of my favorite things, being able to speak with and share with dentists. We have an awesome guest speaker here tonight, supported by our amazing sponsor, Kimberly Pedro and Professional Dental Solutions. They are outstanding. Professional Dental Services, they're outstanding. We're going to be talking about 3D imaging and airway with Dr. Jeff Horowitz. 3D imaging provides clinicians with valuable diagnostic information that can ultimately be used to assess the risk for upper airway deficiency. Tonight, we're going to review symptoms when reviewing medical history, screening with 3D imaging and Prexion software, sleep medicine protocol, sleep apnea, and appliance therapy. I'm looking forward to hearing all about this. Dr. Jeff Horowitz is a self-proclaimed CE junkie. I love that. And whether he is teaching or taking continue ed, it is the key to success in any practice. His special interests include sleep disorders and cosmetic smile rehabilitation. I'm sure he's going to tell us about himself through over the night. So I want to thank you, Jeff, for being here on Nachos CE on TV. We really appreciate it. Awesome topic. And I'm going to turn the event over to you, and I'll be back on in about 50 minutes.
That's awesome, Paul. I appreciate you having me on, and it's always a pleasure for me to get to talk about airway a little bit and cone beam, two of my favorite topics. So thanks for having me on.
My pleasure. I will say there are some challenging parts to being a dentist that are stressful and sometimes exhausting, but one of the cool parts is we get to incorporate new technology into cool ways to help people. So I appreciate you sharing that with the Nacho audience.
Happy to do it. Thanks so much. Well, I guess we'll see you in a few minutes.
Perfect.
Sounds good. Well, everyone, I'd like to say welcome to the presentation tonight. My name is Dr. Jeff Horowitz. I'm going to be talking to you tonight about 3D imaging and airway management. I've been a big proponent of 3D imaging, not just for airway, but for all parts of my diagnosis. We pride ourselves in being a very comprehensive practice. And one of the ways we do that is by capturing data. And where does that data come from? It comes from things like 3D imaging. So I'm not going to spend too much time talking about myself at this point. My information will be listed here. I am an educator for Catapult Education, a key opinion leader where I lecture with a lot of other prominent speakers. I'm also one of the founders of Dentists in the Know with Chad Duplantis and Jennifer Bell, where we kind of followed in the footsteps of what Paul has done here, offering a little bit of information on the backside of dentistry. Not so much talking about clinical as we are just what's going on in the political world of dentistry and in the educational world of dentistry. And so we'd love to see you over there as well. Plenty of room for these different outlets to see what's going on in the profession. My email is listed at the bottom there, and please take note of that. If you would put lecture question in the subject line in any email to me, and I will be sure to get back with you with any information that you need. Not going to spend time giving you my qualifications here. I am a diplomat of the American Board of Dental Sleep Medicine, as well as the American Sleep and Breathing Academy. I've been working in sleep for as long as I've been doing dentistry, started my path with orthodontics and dental facial development in the early 90s. And that path kind of led me straight into airway. So let's get right into it. I do want to give you a little disclosure here that there is not any financial remuneration to myself or any of the other speakers based on product sales or any services that are sold as a result of any of our lectures. But we do want to thank our educational partners that sponsor our lectures, such as Professional Dental Services and Prexion, who are sponsoring this event tonight. And of course, thanks to Dental Nachos for having us on. So let's talk real quickly about some of the economic realities of COVID-19. What do we know about that? We know that our practice overheads have all increased with the infection control mandates and extra PPE that we need and having to take more time in between patients. Things like that have just really driven up the overhead of the average practice. We also know that our revenues have decreased, seeing fewer patients and with a longer room turnaround. So there's another way that our overhead has increased. Plus, it's tougher to get supplies now, and the cost of many supplies have gone up. And then finally, we also know that practice values can decline with a lot of practices going on the market after this pandemic. A lot of people rethinking their lives. So it really behooves all of us in dentistry to figure out ways that we can become more profitable, ways that we can become more efficient in practice and maximize the time that we spend in our dental practice. For me, that's always been about comprehensive diagnosis. I'm a mentor out at the Cois Center and a past scientific advisor. And one of the key components of working out at the Cois Center has been about comprehensive diagnosis and not doing piecemeal dentistry per se. So what are our choices in response to these new economic pressures that we're seeing in practice? Well, we have a few practices that we could engage, and many people, charged a PPE fee or a COVID-19 infection control fee. We all know how that went. Some of us didn't have a big problem. Some people had really big problems. Some people complained to the state, and it was very problematic and certainly not a good long-term answer, although we were able to offset some of the costs there. You could also have raised your procedure fees for the things that you do, but again, in these kinds of economic times and times of uncertainty, how many of your patients are really going to be happy with you with an across-the-board fee increase? So that really didn't seem very practical. Finally, we could lower our overhead by increasing efficiency. And that's what I'm going to talk to you about today. We can add new procedures. We can provide more comprehensive dentistry. And how do we do that? We have to do that by thinking differently. My son is an artist in Charleston, and that's one of his pieces on the lower right. I love that little piece he did just out of a cigar box. And I always use that when I say we have to think about dentistry a little bit differently. Airway is one of those practices that has really allowed us to think differently and to develop a different revenue stream within the practice without really interrupting the regular revenue stream and the regular workings of the dental practice. So this is just a typical day, and this is during COVID actually that you see here. You can see June 23rd, 2020. We were only running one room for myself. Typically I'll run 2 rooms at a time, but you can see I have a whole other column with a dedicated sleep technician in the office, and that sleep technician is going to run her whole room throughout the day, where I'm just going to be popping my head in, and it's a whole other column of revenue. Now, I don't do anything just because we can make revenue from it. I do something because I can A, be good at it, B, offer a great service to my patients, and make my patients healthier, and that should be a win-win. And part of being able to do that by having a dedicated sleep care coordinator is that she is very good at what she does, and it allows me to take the time seeing my other patients and only having really brief encounters in that one room. So this all has to begin by thinking differently. As I said, we should have been looking at things like Airway and TMD all along. What kept us from doing that? Well, a lot of that had to do with the education that we received. So, if I asked most of you out there, what the first thing that you think of when you look at a patient like this that presents to your office, the first thing I'm typically going to hear is, "Oh my gosh, that patient's grinding the heck out of their teeth." And well, regardless of what we do, we're going to have to make that patient a flat plane splint at the end. No harm, no foul. We were all told we could make flat plane splints, and we wouldn't do the patient any harm, and we would protect them from any future bruxism. Well, what if I told you that by doing that, if that patient happened to have had obstructive sleep apnea, that the likelihood greater than 50% that you could make their apnea hypopnea index worse or make their apnea worse, putting them at higher risk for a myocardial infarction, stroke, etc. Would that change the way you think about flat plane splints? And the answer, of course, is going to be yes. So just by the fact that this patient is a bruxer puts them in a higher risk category for having OSA. And we shouldn't be jumping into treatments that we thought were innocuous without at least doing our homework and ruling out some of these other potentially deadly conditions. So, this is called minimizing risk, and it's a principle that I really learned through working at the Coy Center and from teaching at the Coy Center over all these years. And what is minimizing risk? It means we're increasing the positive outcomes for patients by performing procedures that are proven to be most successful. It also means increasing positive outcomes for us as the dentist by reducing negative outcomes for the patient. And then finally, and I think this is the most important thing, and this is probably one of the most liberating moments in dentistry, is when, as dentists, we begin to allow our patients to own their own risks based on a comprehensive diagnosis of their disease and giving them a proper informed consent about what their potential risks are and how they could affect the outcome of any dental procedure that you're going to offer them ultimately. So, what do we need to assess risk? Simple, we need data. Where does data come from? Well, data comes from our medical histories. Data can come from our dental histories. Data can certainly come from our examination that we do, our physical examination that we do. But I'll tell you, one of the largest areas that we receive data from, and when I say data, I mean critical data that help us screen for many conditions and many potential concerns in any case, not just patients who say, I want to be diagnosed comprehensively, is three-dimensional cone beam imaging. So this is the first Prexion unit that I owned. This unit actually went into my satellite office. And let me begin by saying that I've actually been a cone beam user for approximately 13 years. I bought my first iCat machine 13 years ago. I spent nearly $200,000 to purchase the unit. I then put another $15,000 to build the room to put it in because the guideline South Carolina. And I'm going to tell you that was one of the best investments I've ever made in practice as a solo practitioner. And now costs have come down, technology has gotten better, radiation has come down. The ability to take scans on people of all sizes and shapes has gotten better as well. And so this was my first introduction to Prexion, was the Excelsior unit, which went into my satellite office, and a very versatile unit. Took multiple different sizes of scan, very low radiation. Prexion is a company that I was introduced to as having some of the best images in the industry. Why is that? It's because they don't just talk about voxel size, they talk about something called focal spot size as well. And with one of the smallest focal spots in the industry, paired properly with the correct voxel size, we get some of the best images in dentistry at very, very reasonable radiation levels. And so with the Excelsior, I began taking scans on all of my new patients. Yes, I said it, all of my new patients. Now, fast forward to the newest model that comes out, which just came out last year, was introduced, and it's called the Explorer. And that's the newest unit that I've had put in. And how do you differentiate between the two? Very simply, what I would tell you is the Excelsior is a great entry level unit, particularly if you're looking at small fields of view. This would not be the unit that I would recommend for comprehensive diagnosis, insofar as saying you're not going to get the TMJ and the airway and all of the teeth in a single scan. You can, they have a field of view that'll do it. But if that's really the way that you're thinking, then this is going to be the model for you. It's called the Explorer. And the Explorer, you have multiple fields of view to work with. I typically take 15 by 16s on most of my patients. Of course, if they're smaller patients, we're going to do a smaller field of view. But I'm the type of practitioner that when a new patient comes in, I want to assess their risk for their airway. I want to assess the risk for their TMJs and for function. I want to assess the risk periodontally. I want to assess the risk dentally. And I also want to be able to have the opportunity to plan out implants or any other type of treatment that we want to consider from that one scan. I want one and done. Here's the cool thing. I could actually make this into a bite wing as well. Now, this lecture was really touted to be about airway. So what I want you to understand is that when I went into this whole thing with cone beam, I was already doing airway. I was already doing TMJ. And putting cone beam into the office just allowed me to do this at a higher level, because with one scan that can be done as the patient walks through the door, I can be screening for all of these potential conditions. So this is an image that you see here taken with the Excelsior, and I apologize for not taking the name off that. I thought I had blacked through that prior to the lecture. So forgive me for that. But we can take a look at an airway in a sagittal view. We can take a look at it in a coronal view. We can take a look at it in an axial view. Now, keep in mind, this is not a moving airway. So you're looking at a static image of the airway. Typically, this is a patient who has not exhaled all of their air out of their lungs. So this is just giving us a snapshot. So we can see an airway that seems to be of a decent size. And I'm going to give you some qualitative and quantitative measurements that you can use as we get a little further along in the lecture. But for the most part, when I'm doing these snapshot images, I'm just looking for things that stand out to me. So when I see a larger airway like this at rest, can I think, oh, there's no way this patient has sleep apnea? No, I can't say that, because the airway can still collapse even when it's big. But when I see a really small airway with a patient standing up, breathing in and out, and at rest, then I know that patient will be at higher risk for obstructive sleep apnea. So I have other data points that I can capture from the examination, but this is an incredible screening tool, and I'm going to show you why. And that's because sometimes people will lie to you when you hand out screening tests. When you ask them, do they snore? When you ask them, are they tired? They will flat out lie. Now, this name I did intend to keep on here because this is the name of one of my associates. And this associate told me that he didn't snore, told me he didn't have a problem with sleep, told me he didn't think he needed to be screened for sleep apnea. And when we took our Prexion scan on Dr. Bachler here, and he has given me permission to do that, by the way, when we took our scan on Dr. Bachler, we see a critically small airway at the C2 region. And if we look at it from the axial view, you can see that it's almost entirely collapsed. This is while he is standing upright and breathing in and out. As it turned out, not just apnea, but severe apnea was the diagnosis. So I want you to see this as a tool that can be used for every patient, not just patients who come into you for an airway exam, not just because you're starting to do airway, but because this is a comprehensive patient that you are trying to reduce risk for long term. So the conversation comes up when we go into the room. You know, Mr. Jones, I looked at all your teeth and I was looking at your jaw joints and I was looking at everything important to us in dentistry, but I also noticed that you have a critically small airway, and that can be very dangerous. So tell me about your snoring, because it would be really unlikely that someone with an airway like that wouldn't be snoring. And it begins to make sense because they start to accept that now as part of the anatomy that you're reviewing as you look at a comprehensive scan. So when the patient says to you, "Why are you looking at this? You're just the dentist. Isn't that a medical problem?" Well, yes, it is a medical problem. It is a medical diagnosis, but as dentists, we are gatekeepers of the airway. And I have to tell you that breathing does trump teeth. Now, teeth are important. I love teeth. I love to fix teeth. I love everything about teeth. I love to keep teeth when I can. But if I have a patient that has sleep apnea and treating their sleep apnea may mean risk to some of their teeth, then that's the patient's choice, not mine. So if this patient walked through my door, couldn't tolerate CPAP, and said, you know, I have severe apnea, I can't wear the CPAP, I'm not a candidate for surgery, could you make me an oral appliance? Most dentists would say no, because they'd be afraid of what's going to happen to the teeth. Well, this guy's already pretty jacked up, and I don't think you're going to do anything to the teeth that wasn't going to happen already. So we tell them, we let them know it's going to make the teeth worse before it makes them better. Maybe we get the teeth out right away, put some implants to stabilize an oral appliance, and off we go to the races. But it's not for us to tell a patient to go home and die because we're worried that, you know, their periodontal disease may get worse or their tooth could be lost sooner, especially when they were in such bad shape to begin with. So we just have to think more holistically than just being confined to individual teeth. So, and this is why this is so important. And it's because, you know, a patient that has undiagnosed or untreated OSA has one of the highest risk factors for future heart attack or stroke. Now, this is very well understood data throughout the industry. So someone who's overweight has 7 times the risk of a future myocardial infarction. Someone with high blood pressure has 8 times the risk. A smoker has 11 times the risk. But someone with untreated or undiagnosed OSA has 23.5 times the risk of controls of having a future heart attack or stroke. Well, that is pretty compelling. We also know that a lot of our patients that come in with other medical problems are very likely to have OSA just based on the fact that they have these other medical problems. So I'm not going to go through this whole list of comorbidities. I just want you to pay attention to some of the statistics that you see here on the right, showing the likelihood of somebody having OSA with these different conditions. And these are all things that we see every day on our medical histories. So the problem and my mission is number one, only about 10% of OSA sufferers have ever been diagnosed. Most often, it is not going to come from their primary care physician. It's going to come after a critical event that they have, whether it be a heart attack, a stroke, or some other gross sign of having OSA. Only 10% have been diagnosed, and only a quarter of those have been successfully treated, typically because CPAP is touted as the only option or the only viable option. And these patients get railroaded into that therapy when oral appliance therapy could be indicated. So here are some of those red flag medical history findings. Again, I'm just telling you to use this as an adjunctive tool. And when you see any of these things, especially when you look at your cone beam and you see a smaller airway size at rest, I really want you to have the hair stand up on your neck and go in and have the conversation with the patient. I've told you the two most common symptoms of OSA: snoring and excessive daytime sleepiness. Those are the big two. So ask those questions. You don't need to hand out these big screening tools. I mean, the last thing that patients want is more paperwork to have to fill out. They're already filling out another COVID questionnaire now. So don't give them any big screening tools like that. Ask them a few basic questions and get your airway image. You can do a stop bang. I'm not going to go into that. This is a very easy 8-question screening tool. There's even a smaller one, a 4-question stop tool that you can use. I'm happy to share any of these with you if you'd like to email me at a later date. Again, this is mainly about cone beam. Today, you can offer an Epworth sleepiness scale, which is the gold standard in sleep apnea. Again, any screening tool that you use is just a screening tool, and it has to be put together with data that you also capture, and even more importantly, that you can show to the patient. And again, where does that come from? That's going to come from cone beam. It's going to come from your examination and what you see based on the cone beam. So we can do a Mallampati classification. We can do pharyngeal grading, looking at the lateral dimensions of the airway. We can look at the size of the tongue and for structures that visibly obstruct the airway. And as an adjunct, I would also tell you that when you're looking at your cone beams, you also want to be looking at tonsils and adenoids. So we can do tongue grading, looking at the size of the tongue with reference to the size of the arch form and whether or not they're going to be a high-risk case or not, whether their tongue is scalloped or not. But I'll tell you, by and large, the one thing that always jumps out, and remember that very often people don't tell you what their true symptoms are, is having these images, having these cone beam images as one of your first screening tools. And again, I'm not just taking a cone beam to screen for airway. I'm taking a cone beam on virtually every new patient that walks through my door if they've not had a cone beam image taken within the last couple of years. Again, it's going to be full field of view. So I'm going to be looking at joints. I'm going to be looking at airway. I'm even going to be looking a little bit at cervical spine because of my knowledge in the TMJ. I'm going to be looking at the periodontal structures. I'm going to be looking at the tooth structures. I'm going to be looking at the nasal airway. So I would love for you to take a look at this. This is typically how we would catch a small pharyngeal airway. This is an axial view. So the axial view is that view taken slices through the head from the top down. And we can see that this is a patient who is at rest and standing up in the machine, and yet the airway is almost completely collapsed on one side. Minimum cross-sectional area is a term that we're going to talk about here shortly. But all in all, you can't diagnose what you don't see. That is probably one of the biggest points. So whether you're doing implants or whether you're thinking about, looking at the teeth with cone beam or planning for implantology or whatever it is that you want to use cone beam for, think more holistically. Think about all the things that you can be doing with this cone beam image and never fail to look at that airway. It's right there for you. You don't have to look that hard, and you don't even have to have a full field of view, depending on the patient's size every time to see that. Now, one of the beautiful things about the Prexion system is this beautiful airway analysis tool that they've built into the system. So they've taken very well understood data, knowing that when the minimum cross-sectional area of the airway at its smallest point is less than 1.86 square centimeters, that we have a higher risk for obstructive sleep apnea. Again, one of the things I want you to take away from this is that just because an airway is big on a cone beam, it does not mean that the patient cannot have obstructive sleep apnea. But what I will tell you is that when a patient is alert, awake, standing up, breathing in and out in the machine, that we should not see airways of this size. So what does Prexion do to alert us that we might have a problem? Well, we simply put this airway analysis tool in, and I've learned to recognize these things, but this is very useful, especially when you're first getting started in airway, and it's going to pick up all of the areas of restriction, starting in the areas shown in red, and then the areas shown in black are way below that accepted norm for minimum cross-sectional area that would put a patient at higher risk. So boom, just by taking the scan, this patient is already flagged higher risk for OSA, and we're going to start that conversation of getting that patient diagnosed. Again, cross-sectional area, minimum cross-sectional area is the most important number that we are looking for. Why is that so important? A lot of companies out there will talk about volume and the volume of the airway. Well, if you think about what volume is really just the cross-sectional area of the airway across different sections. So in other words, it's the average minimum cross-sectional area. So volume, when it comes to the pharyngeal airway, is not as useful a tool as the minimum cross-sectional area at the smallest point of the airway. I really want you to take that away. And what the software that Prexion has put into their system does is show you those areas very clearly. And now I can walk back to the patient and show this very, very easily. So we can also look at the coronal view. We can find areas that are small there. Again, this airway tool is going to work in 3 dimensions for us. We can superimpose it over the facial bone, showing the extent and the position of the constriction. So that shows the patient where it is with regard to the face, and why you as a dentist would be looking at this and talking to them about airway. It becomes an absolutely critical tool. Here's the other beautiful thing that we can do is we can now look at these models, and let's say we've treated a patient and we've repositioned the mandible. We can actually see the impact that it has on the resting airway with repositioning of the mandible. So this is the same case that I just showed you, and you can see the difference in size as we look down at this axial view. Now, would I call this perfect? No, but if we looked at that side by side with what I showed you before, you can now see that the minimum cross-sectional area is vastly increased. And in fact, by sleep study, it was proven that this patient was now apnea free, which is a pretty amazing thing. But we can see the physical changes to the airway. And why is that important? That's important too, because everyone seems to think that because we primarily move the mandible forward in an AP motion with an oral appliance, that's where most of the increase in the airway occurs, is in this AP direction as we look at the sagittal view. And that's actually not the case. We actually see more oblique opening with oral appliance therapy, as you see in this case here, taken in the coronal view. So again, this is that same case. And what I love the most about this case, and here again is that image that's superimposed. What I love the most about this case is that it happens to be me. So when Prexion, because I've been working with them for so long now, not just back in the days of the Excelsior, but with regards to giving them feedback in the development of the new Explorer model and what tools are important and what metrics are important. And one thing I will say about this company is that they absolutely listen, and they are a wonderful company to work with. Their support is absolutely terrific. It is second to none. I can tell you, I have a unit in each of my offices, and in both of those offices, regardless of what the problem is, if there's ever an issue, they call up. The phone is always answered by the second ring, and we have a fix immediately. And if the fix is not immediate, someone is on an airplane. And that's only had to happen once, and it happened. Someone was on an airplane. I can tell you that was not the case with my iCat. So I've really enjoyed, again, working with Prexion and offering feedback. You know, one of the things that I always tell dentists is when you're looking at cone beams is don't get sold on the prettiest picture that gets thrown up there. And by prettiest picture, I mean, yeah, this has a lot of fancy colors and things, but what you're looking at is a volumetric representation of the airway. And again, if you remember what I told you, volume is not as important as the minimum cross-sectional area at the smallest point of constriction in the airway. So please, please, please remember that. That's a great little tidbit to always take into account. And here's some of the data that really explains that. Now, I don't have time to go into a lot of this now. I'm happy to share any literature, any studies that support everything that we've just talked about. But again, what I want you to see is that across all of the literature, one of the most indicative data points is the fact that people with OSAS and severe OSAS have significantly narrower cross-sectional areas at the level of the uvula or at the level of C2. And across all the data, we see the same thing, that minimum cross-sectional area is one of the most important data points to capture. So I also want all of you to know that this starts in kids. This is how my path into airway and dental facial development really started, was through orthodontics in the early 90s. We started doing palatal expansion very early. We were improving airways in young children. As we did that, we were able to overcome enlarged tonsils and adenoids sometimes. Sometimes we had to refer them to the ENT. But this is typically where the disease starts, and it's up to us to catch that. So there's a lot of things that kids will come in with, you know, cross bites and mouth breathing and teary eyes, allergies, high palatal vault. These are all telltale warning signs, and I want you to pay attention. You know, one of the things that I always hear is, Jeff, are you crazy? Are you taking cone beams on children when they come in as new patients? And I say, you bet you I do. You bet you I do, because not only can I evaluate the tonsils, the adenoids, I can look at their growth and development. I'm getting a panoramic image. It becomes my pre-orthodontic image because I can develop a cephalometric analysis just based on the one scan if it's taken in a large field of view. You betcha I'm going to do that. And there's not going to be a need for a lot of other intraoral x-rays. And I can show you where over the course of 5 years, I will subject that child to less radiation, having taken just that one scan, and then using, other tools for the diagnosis of caries. Even with that, Prexion has done some incredible things because of their image quality and the size of their focal spot. We can actually develop bite wings from from our Prexion scans. We can actually get images of the teeth, bite wings per se, that we can look at and not only see them, as we typically do sagittally in 2 dimensions, but also look at them coronally and decide, where is the worst point of decay? Is it more to the facial? Is it more to the lingual? So important to see that we can look at adenoids. The only other way to look at adenoids going to be to shove a mirror back behind the tongue. I'm not doing that on young children. We can also see all the tonsillar tissues that surround the tongue and the pharyngeal airway and look for potential problems. This becomes a great referral tool for your ENTs, or maybe to your orthodontist if you're not doing orthodontics yourself. So there's a lot of reasons. You're building up that networking for you, for your practice. You're working with medical practitioners, offering referrals, and it's all because you were taking a scan at the beginning and offering your patients a comprehensive diagnosis that minimizes risk. So we've been doing this stuff forever. We've been expanding arches. We've been improving airways. We now have a quantitative way and a qualitative way to actually look at these structures in real time when our patients come in, and have a more accurate idea of what's happening in patients of all ages. It offers us the opportunity to do things like Invisalign first, like expansion therapy, again, referring to the ENTs. For adults, it allows us to work them into mandibular repositioning appliance therapy. So lots of things that we can do with this. So typical patient, I'm just going to throw a case at you really quickly. This is a patient that had a sleep study, came in with an overall AHI of 48, an overall RDI, respiratory disturbance index, of 56, was spending 20.4% of the night under 90% oxygen, had a maximum heart rate of 130 beats per minute, and a minimum oxygen of 70.9%. This is an airy sleep study that we did. Well, that's pretty darn scary. 20.4% of the night under 90% oxygen, low oxygen of 70%, and a max heart rate of 130. This is a heart attack or arrhythmia waiting to happen. So we put them through appliance therapy based on the risk factors that we found. So we got them this comprehensive diagnosis signed by a board certified sleep physician. If you go to the last test, that was his diagnosis based on the fact that we saw risk on the cone beam. We get a signed sleep study saying that oral appliance therapy was indicated. This was our follow-up study after appliance therapy. Now the patient's apnea-hypopnea index is 8. The overall RDI 23. Time under 90% is 0% of the night. Maximum heart rate. You really think you can affect cardiovascular health, Mr. Dentist or Mrs. Dentist? Maximum heart rate, 86 beats per minute now. Minimum oxygenation, 90.7. That's a great day. That's the face you make the first time you hear the band Rush. I'm sorry I had to do it. I am a diehard Rush fan, And I just can't ever seem to get through a lecture with putting something on there like that. So thanks for indulging me there for a minute. You know, the big takeaway here is that we all need to stop thinking like dentists. We are oral health care physicians. And I want you all to think like that. You know, it's not about the tooth that broke. It's about, why did the tooth break? Did the tooth break because there was grinding? Was the grinding there because of a bad airway? Why did the tooth break? Did the tooth break because there was no posterior support? Why was there no posterior support? Because there was a bad jaw joint. I want you to think more comprehensively. But at the bottom of it all, we have to always look at the airway first, because the airway is the thing that has the potential to take us out. It's not our job as a dentist to say, don't worry about that airway because it's a medical problem. I've got teeth I need to fix. When you make these discoveries and when you discuss this with your patients, it's like you've opened a whole new world, and you now have patients for life. The patient that comes in and says, Dr. Jeff, I want an implant. Yeah, I could get in there. I can use the Prexion implant planning tool. Really easy. Boom, I can throw an implant in there. I know what size. I have the whole database of every implant system that's out there. So I can drop any type of implant that I place into three-dimensionally into my Prexion images. This is just a beautiful tool that they offer. But guess what? I don't just take that field of view that shows me the fact that they have a missing tooth and can I fit an implant in there. Uh-oh, we've got a bad joint. And I start asking about popping or clicking. I'm just going to tell you, this is not what the condyle should look like. We don't have time to really go into that. But as we look closer at the TMJ, again, here's your sagittal view. This is supposed to be nice and rounded. This is about half the height that it should be. This is completely broken down, flat, with osteophytic change. This patient has a lot of pain. They don't have a lot of space. As we look at the coronal view of the condylar head, you can see more of the osteophytic change in the joint space. This is a patient that's been debilitated with TMJ issues as well. And I found it because they came to me to talk about an implant, and they just been told so many times by their dentist that they don't really do a lot with TMJ. There's nothing you can really do about it. It's just something you have to live with, or you just make a flat plane splint. I don't care if you're an expert or not. Find the people around you who are, and be that person that helps patients find answers. Again, be that health care, that oral health care physician, as opposed to that tooth doctor. And it's amazing what happens. And by the way, this is what the healthy TMJ should look like. This is the right side. So this is a patient that had a traumatic injury to the left condylar head. As a result, they were experiencing breakdown on the left side. Vertical dimension was being lost on the left side. Eventually, they started biting too heavy on the left side. And guess what? They lost that tooth that we've now had to treatment plan for an implant. So remember, it's not about, did you lose a tooth? It's, why did you lose the tooth? And that's what my Prexion's going to tell me. And oh, by the way, has anyone ever told you that you snored? Again, same patient. Has anyone ever told you that you snored? Why would you ask me that? Again, I'm not trying to pile on. I know you came to me about an implant, but in our practice, we try to find out the reasons that things happen so we can prevent them from happening again in the future for you. So when I look at this scan, this airway should be wide open. I didn't even have to run the airway tool on this because these tissues are touching each other. But if you want to run the pretty tool, run the pretty tool. And now you have something you can hand to the patient and say, take that home, and ask your husband, your wife, your bed partner, whatever, do I snore? Because my airway is closed when I'm standing up and breathing normally. And so this is going to be a patient, at least send them home with a pulse oximeter. Find out if they have an airway issue. You could add 12 to 15 years to their life expectancy just by taking that one darn scan. So what happens when we learn about airway? What happens when we learn that capturing data with cone beam imaging can really not just be a way to boost revenue, but to be a way to improve the type of care that we're providing to our patients? It's going to add a new source of practice revenue for you that requires minimal doctor time and minimal effort. You're going to provide more comprehensive dentistry. You're going to help your patients get to not just the what's wrong, but the why it went wrong in the first place, and keep them healthier, preventing that from happening again. You're going to decrease your overhead by providing care efficiently. You're going to have less chair time. You're going to have more profitability. You're going to add procedures to what you're doing. You're going to decrease your patient risks medically and dentally, and you're providing a true quality of life service that saves lives. So, not just airway, the imaging, it's everything that you find. It's that data that you find and the data points that we can share with our patients that talk about risk. So, I graduated from this old ICAP machine. I can tell you that this was a $200,000 machine, which I made my money back on in the first year, just based on the number of TMJ and airway cases that I was doing, not to mention how many patients were moving forward with implants, because I could plan them and tell them whether they were eligible candidates that very same day. So when that $200,000 machine became old and obsolete, what did I do? I moved to the Prexion at half of the cost. And when I moved to the Prexion at half of the cost and twice the image with a smaller focal spot and lower radiation levels, and now I was able to graduate from my Excelsior to the Explorer, which offers me fields of view similar to what I was getting with my iCat, and I'm getting lower radiation levels again and better clarity, and my patients can be unobstructed. They don't have a gantry that binds down on their shoulders. They don't have this big bar that has to get around them, which was tougher for bigger people. You know, it's really a simpler choice. What I love about these stand-up units as well is that they will accommodate a wheelchair. So if you want to sit someone down, you can. If you want to stand them up, you can. The versatility is absolutely outstanding. So with that, I'm ending at about 10 minutes till. I wanted to say thank you again to Prexion Corporation for always listening to my input and for doing such an amazing job on the customer service side. Because as a speaker, and again, I get nothing if Prexion sells units to anybody or anything for any service sold. What I do get is the satisfaction of when I make a recommendation like that, that I know it is a phenomenal company and I know that they walk the walk, because I have these units and they service my units and everyone that I've ever recommended them to in the same exact way. I also want to thank him and Professional Dental Services, the outlet that you can work with if you're considering getting into a cone beam purchase. And then certainly Paul and Dental Nachos, I want to say thank you for giving me this opportunity to blow some wind about airway and about imaging and some of the things that are so important in my practice.
We appreciate that, Jeff. We're going to ask just one or two questions, but I have a special treat. Every time Kimberly does sell one, I will send you a bag of these for you to have down there. So, you know, you won't leave empty-handed.
I love it. My wife made chili yesterday, and there's nothing I would like better than to dip that into the chili.
So we had some great people on Zoom, great people on Facebook. One question that was happening was, how do you handle edentulous patients who cannot tolerate appliances in their mouth? I'm not sure if I'm asking that right. was by a very nice
Yeah. So
dentist.
no, I know exactly where they're going. So can you make an oral appliance in an edentulous arch? The answer is yes for the maxillary arch with the suction that some of the manufacturers are able to get. I will tell you, and again, I get nothing from Somnomed for saying this. Somnomed makes a great appliance. They understand denture fabrication. They've been in the market for a while. So when I have a maxillary edentulous arch, I will typically go with a Somnomed appliance. For the lower arch, you do have to draw a line in the sand. You need some type of retention, which is either going to be 4 mini implants or 2 conventionals with locators.
Awesome. Thanks for sharing that.
Yep.
Another question with the Prexion, how do you handle broad-shouldered folks in the CBCT? Is that a problem?
So that's the beauty of this unit, is the fact that you can either put someone in the chair if you need to, you can stand them up. Between the different configurations and the ability to move the gantry around them, we have much fewer snags with this machine than we ever did with our iCat. I can tell you one of the concerns with the iCat is we would always have these, head cocked, and we'd have to do a lot of corrections for bigger folks and patients with shorter necks. So just the versatility of being able to sit them down or have them stand up, along with the easy gantry movement inside as you're placing the patient in, it makes it a really simplified process to avoid that.
Awesome. That's great. I want to share that if you're watching live, one of the benefits, you get live CE credit. My awesome team will put that into the chat. I'm not going to say it on the video because if you're watching on demand, there's going to be a quiz. If you're watching on demand after this is done live, you'll do a quiz. You get self-study C. If you're watching live right now on Zoom, we're going to drop in the chat the code.
Do I have to take the quiz, Paul?
Yeah, you could. I made the questions. Hopefully, you got them. I make the questions. Well, yeah, there's always some nacho themes to it. What are 2 common signs of sleep apnea? Love of guac was one of the. That's not the right
love
answer.
Of guac. Okay.
People ask they can't get the recording. Yes, you can get a recording of this if you email 3D Airway nacho course to Flix FLIX at dentalnachos.com. And I know you're going to jump off in a second here to actually have just one more question, but I also wanted you to share what is that Facebook group people can join that you are started. It sounds awesome that you mentioned in the beginning.
Thanks so much, Paul. And it's because of pioneers like you that jumped out here and started these types of forums that it's allowed us to see some of the needs. So in Catapult, we provide a lot of education. Where we saw a need is that all of the people we were teaching would say, hey, where do I learn this information? How do I know who runs this company? How do I know who manages this company? How do I find out what's going on in the political arena? So we developed this group called Dentists in the Know, Chad Duplantis, myself, and Jennifer Bell. Dentists in the Know, we're a Facebook group. We're a little over 2,000 members right now and increasing every day, but it's really just great information for dentists out there. Tonight we're going to do a thing about the world of dental education in the COVID world. So we're going to have a dental school professor, dental student, and, we're just trying to talk reality and help each other any way we can. So
I love that.
Appreciate you mentioning
sharing
that.
Awesome value. I mean, you never can do that too much. Sharing more, caring more. We needed this years ago. We didn't have the platforms for it. So I love that social media can do that. Now, before you jump off and run, and I'm going to pick this up with Kimberly, but let's say somebody's watching, they're inspired by this, they want to do it. This is a question I often have. Where's the first step for the medical billing part? I know you people like you are now experts, Jeff, but if you were just starting out and said, I want to do this, I want to help patients, what would be your first step to find out or go to for medical billing?
So sorry. I was just going to say, I've got the answer to that this evening.
Okay.
I am offering to anybody 1 full year of medical billing at no charge.
That's awesome, Kimberly. We're going to talk about that.
The cone beam. So that will definitely help if they're interested in going into medical and Airway.
And Kimberly, to that point, my answer was going to be one word: outsource.
Yeah.
Do not try to figure this out in your own practice with your own dental team, because if you want unhappy employees, tell
Right.
them that they have to learn how to medical bill and do it correctly. And it asked me how I know that.
Yeah, right. I can see it. Well, Kimberly and I are going to stay on and talk a little for a few minutes here, but thanks so much, Jeff. We'll have you
Thank you,
back on
Dr.
for
Horowitz.
another episode. You can stop
Absolutely.
sharing your screen, and Kimberly and I are going to stay on and talk a little bit about her support for this and stuff. But thanks so much. Great to meet you face to face here, and hopefully you meet in person one day soon.
Absolutely, guys. Have a great night. Thanks again.
Take care.
Awesome. So that was an awesome CE course by Dr. Jeffrey Horowitz. Thanks, Kimberly, for supporting us. You've been an amazing key resource and sponsor. We had an awesome course with Dr. Lou Graham. If anyone would like a copy of that course, it was great. It was hilarious. Just text CBCT to 215-543-6454. We'll have this one up soon on our NachoFlix platform. But Kimberly, you just helped a Nachoer get started with Aprexion. Tell us a little bit about what PDS does, how people can reach out to you, and some of the deals that you have.
We sell and repair equipment in Arizona. However, there are some items that I sell throughout the United States, and one of them is the Aprexion cone beam.
Awesome. And you just installed one in a Nachoer office. What's the process? Like, let's say someone's watching saying, hey, I want to invest in this by the end of the year. How can they reach out to you to get the best deal? And what's the process of getting it installed?
Sure. They can reach out anytime by email, kimberly@pdsaz.net, or on my cell phone, 602-214-0001. Call me anytime, not a problem. So the process usually is I will talk with the doctor and just find out what the practice goals are and what they're going to be using the cone beam for.
Perfect.
I have some doctors that say they just want to use it for a single implant. They're just starting to get into that. They're not looking for the larger field of view.
And I'll have to share, we purchased our cone beam before I met you, but I was a little reluctant. I had myself and a board certified periodontist. We've been doing implants for years. We would do the mobile CBCT for big cases. We thought, we didn't need it. And I would have liked to have gotten into it sooner. Most dentists, especially on COVID, gets concerned about cost. Could you give us just round numbers of what a monthly cost is to have this in your office so we can relate that to how many scans we would take to be able to cover that payment?
Sure, the monthly payment is $1,000.
Yeah, so that's just so great, dental Nachoers. Think about adding $1,000, whether you charge between $250 to $400 for a scan. Also, it replaces your Panorex. It's a true Nacho brainer, and I'm sharing with you something I wish I had done earlier. So this is a great opportunity, whether you're going to do implants, endo, start doing sleep stuff, and also Dr. Lou Graham's course, he talked about how he uses it for just basic comprehensive dental care.
It's a great time of year thinking about Section 179.
Yeah.
You can ride the full amount off on your taxes.
That's awesome.
Axial unit comes with a full 10-year warranty on parts, 5 years on labor. There are no hidden fees. So when you think about it, you're not going to be paying anything out.
And what you really are, Kimberly, which is great, is you're a one-stop shop also for education, for training, for finding out who to connect with to have the CBCTs read. What company do you usually have your clients use for reading of the CBCTs?
For reading of CBTs right now, I have a special with Beam Readers.
That's
They
great.
are offering 8 hours of CE on helping on how to read those scans. After that, the first 4 scans are $25. And then from there, every scan is $85, up to $100 for the first year.
So yeah, I mean, it's made dentistry a little more fun too. I was just in my office yesterday, and we were taking some scans for implants, and I was playing around looking at some other teeth, and sometimes you go, man, some of our teeth are barely held in by much buccal bone, even the ones we have, and I think it just makes us a more complete practitioner. So I love what you're doing, Kimberly. One more time before we jump off Facebook Live, just share if someone wants to reach out to you directly, what's the best number and email?
602-214-0001. Kimberly@pdsaz.net. And I want to mention that I will be on sometime in December adding the watermark sleep test take home device.
Oh, awesome. That's going to be great. That's going to be an awesome time. You also can reach out to us at dentalnachos.com or text CBCT to 215-543-6454.
Sounds great. Take care and happy November.
Thanks, Kimberly. Awesome. So off Facebook Live, we still have some people here on Zoom. So if anyone on Zoom who saw this awesome course, I know some of these nice people in the chat. I don't want to call anyone out. If you have any questions for Kimberly in the chat, feel free to let us know. Yeah, the person that you just installed it for, he loves it, Kimberly. He loved working with you. And anything else you wanted to add for us? Or that was an awesome course by Dr. Horowitz. So thanks for keep bringing these awesome speakers to us.
Of course, and I'll continue. And no, I just appreciate all the opportunities. I've had a lot of questions. Don't hesitate to reach out anytime.
Awesome. Yeah, you're a great resource. If you go through those Facebook Live comments, there were some people asking some questions too in there. I tagged you a couple of times because they were asking. It's always, I have to share it. We have someone who does sleep apnea, GP who's focused on it, but he's like a Dr. Horowitz who, he has been doing it for a while. He's mastered the medical billing part. As a practice owner, I think that's weirdly the biggest hurdle to think how we're going to do it. So when you can outsource it, like you said, it seems like that's the easiest way to do it.
It sure is. And you'll get that cone being paid for in under a year.
Yeah, that's awesome. Well, thanks for everything, Kimberly. We appreciate it. Everyone
Take
watching
care.
in, have a great rest of the night, guys.
Bye, everybody. Take care.